Hey everyone, this is Ensign Flood here. We're going to talk about hepatitis today. So hepatitis is a virus that infects the liver, and in the case of hepatitis B and C, can cause chronic hepatitis leading to cirrhosis and potentially hepatocellular carcinoma. So if you have a patient that is feeling fatigued, they're weak, they have jaundice, or they have hepatomegaly, you're likely to do an LFT, so the liver function test. And what's on that panel will be the transaminases, so AST and ALT, which are indicative of hepatic stress. And the degree of rise from the norm will tell you a little bit about the etiology. So where we like to look in terms of acute viral hepatitis is an extreme elevation, sometimes as high as the thousands, but not necessarily as high as you'd find in shock liver like ischemic or toxic shock. Some people like to look at the AST and ALT ratio. I personally find this more helpful to confirm alcoholic cirrhosis, so that's ratio greater than 2. Remember that because the liver is inflamed, sometimes it can compress upon the biliary tree, and that stress is monitored through ALK phos, so ALP here, and GGT. So of the two, GGT is a little bit more specific because ALK phos can also be found in bone and placenta. Remember, a lot of the time these patients come in with jaundice because they have an increase in their total circulating bilirubin. So basically, jaundice becomes visible here at greater than 2 to 3 milligrams per deciliter. So talking about the different hepatitises that we've probably heard about in pre-clerkship, you have hepatitis A through E. So I group A and E together in blue to remember vowels, hit the bowels. So vowels hit the bowels because A and E are both transmitted through the oral fecal route. It's typically jaundice and a lot of nausea and vomiting, diarrhea, and self-resolving. Hep E of note can cause maternal fetal death by fulfillment infection in the 3rd trimester. That's all I'll say about those two. Hep D is typically clinically irrelevant on its own, but if you have an existing chronic hepatitis B infection, and get this, it can create a super infection. So that's all I'll say about D. The major hepatitis that we'll talk about today, or the major two, will be Hep B and Hep C. So Hep B is the only one of these that's a DNA virus. The rest are RNA. It's transmitted sexually and vertically. Hep C virus is more associated with your chronic hepatitis, and this is typically seen in IV drug users. And you want to screen people who were born between 1945 and 1965 for hepatitis C. So when you monitor hepatitis C, it's a little bit more straightforward. All you're looking at is typically the IgM, which is going to indicate an acute or ongoing infection, and IgG, which means that you have a resolved infection and immunity. If you have a chronic hepatitis C infection and you're trying to look at the efficacy of treatment, you will probably be monitoring the viral loads through a PCR for that RNA. Sometimes you might see vignettes where they talk about biopsies. These seem to be falling a little bit out of favor, but are very definitive. If they show inflammation or fibrotic change, you're going to want to start antiviral therapies immediately, even in the absence of symptoms, because this will lead to cirrhosis, which is irreversible. So I'm just going to basically circle these antivirals a few times because I can't pronounce their names very well, so I'm really sorry. The other reason you'd want to treat is if these patients have symptoms, and that includes transaminitis, so elevations in those AST or ALT. So looking at Hep B serology might seem a little bit scary because we remember all of these kind of complicated graphs and timelines between the different markers, but I want to simplify it by just using this graph up above. So basically, I look at HB core antibody, HB surface antigen, and HB surface antibody. So the core should tip you off to exposure, meaning this person has at one point in their life actually been infected with the virus. So the only case that you wouldn't see the core antibody, well, 2 is technically if they've never had the infection in their lives, or if they were immunized before they ever had the infection. So everything else is a plus. HB surface antigen, antigens means that there's an infection, right? So there's 2 different flavors of infection. There's acute and there's chronic. So those are the only 2 times you're going to see the antigen. Hepatitis B surface antibody, so that's how we make our vaccines. So there's 2 ways you can get this. It's indicative of immunity, meaning the body had the infection or it cleared it. or you were immunized before you ever got the infection. So hopefully this clarifies serology a little bit for you. Now we have the same basic story with the biopsy. If you see those infiltrates or fibrotic changes or transaminitis or other symptoms, you want to treat these viruses, are treated with tenofovir and lamivudine. And you might see interferon as an option. This is becoming a little less popular because of the flu-like side effects. But really, you should just try to vaccinate. We like to vaccinate children starting at 2 months. We also like to vaccinate healthcare workers and intravenous drug users. So the feared consequence of chronic hepatitis, be it B or C, is cirrhosis and eventually hepatocellular carcinoma. So I like to look at Cirrhosis Man, as I call him, to remember all of the different types of complications here. So sorry he's a little bit scary, but let's just talk about kind of 3 major contributors, as I see it, to the different signs and symptoms. So the first should be the really overt, which is that this person is going to have a cirrhotic liver, meaning because this liver is all fibrotic, hard, and kind of enlarged, you can basically feel it. So hepatomegaly, it might be blocking off the biliary tree, so this patient's going to have jaundice and itch a lot. And don't forget about the portal vessels which run through the liver. They're also going to be blocked off, so you get portal hypertension. Because that's such a major vessel, the body compensates by making varices elsewhere, so you might get them around the umbilicus. Or where it's really kind of dangerous is in the esophagus, and if those varices rupture, you have a medical emergency. Don't forget that the liver is really important in making different proteins. So thinking about the loss of function here, if the liver doesn't make albumin, then you're going to have these abnormal fluid shifts. So this is why these patients get kind of the potbelly ascites. And this ascites can become spontaneously infected. It's called spontaneous bacterial peritonitis, so really dangerous. Look for that with fevers, etc. These patients can bleed, so besides the varices, don't forget the liver is responsible for making your different coagulating factors. They can also become immunodepressed, so basically low Igs and reduced acute phase proteins. So don't forget to keep current on the vaccines. I alluded to those on the answer page that you guys have for GI Week 2. So the next type of clustering that I like to talk about is excess estrogen. So I think about red estrogen because you get these little red spider angiomata. You can have palmar erythema, so red palms, right? You can also have gynecomastia in men and hypogonadism. And kind of like what you'll see in pregnancy, you can actually get this increased thyroid binding globulin. So basically that binds the free T3 and 4, but doesn't change the total T3 and 4, so TSH should be normal in the labs. And then finally, these patients can get encephalopathy second to excess ammonia, so really dangerous sequelae right there. So in summary, don't forget to look at the LFTs because those are going to point to the etiology. Remember that Hep B is the only DNA and Hep C is RNA, and those two can become chronic. Vowels like A and E hit the bowels and then they resolve after a bunch of nausea and vomiting. Hep C, you're going to want to track the IgM if it's an acute infection, the IgG if you have immunity. Hep B is a little bit more complicated, but not too crazy, right? When we think about HB core antibody means you're exposed. HB surface antigen means you're infected. HB surface antibody means you're immune. And don't forget to look back to Cirrhosis Man, really high yield right there, and that these patients are at an increased risk for hepatocellular carcinoma. All right, great job, guys. Study hard.